So the next topic is also about the intestinal tract, and we will discuss the role of radiologist in inflammatory bowel disease. Okay, so inflammatory bowel disease it includes these two diseases. One is the ulcerative colitis. It is a superficial inflammation of the mucosa, and its continuously inflammation begins in the rectum with retrograde spread. It may have a complication of ruminant colitis. And the other one is Crohn's disease. It is a transmural inflammation of the intestinal wall, and it is involved discontinuously with multiple skipped segments, mostly involving the colon and the ileum, but it may also involve stomach and esophagus. And it can have perianal involvement and can have penetrating complications such as sinus tracts, fistulas, and abscess. So for the imaging of the inflammatory bowel disease, the state-of-the-art cross-sectional imagings, the tools we have are here. One is the CT enterography, and also we have MR enterography. And recently, the intestinal ultrasound is getting more and more popular. And we start with the first case. It's a 13-year-old boy. He had chronic abdominal pain and diarrhea for 1 month. And there is body weight loss, and also there is elevated white blood cells and elevated CRP. The stool cultures were negative, so the infection disease is less likely. He had a colonoscopy and is inserted into the terminal ileum, but it looks normal and no organic lesion were found in the colon and the ileum, and terminal ileum. Okay, so this patient, the clinical symptoms is suspected to have an IBD, but the colonoscopy is negative. So we want to examine the small bowels. So what would you recommend as the next examination tool? Okay, these are some choices. Okay. So actually there is no single correct answers. We can choose different kinds of image tools, but usually we will choose the less invasive ones first. So these cross-sectional images can be considered. Can be chosen based on the preference of the clinical doctors and the facilities in the hospital, and also can consider the capsule endoscopy. And a deep endoscopy is more invasive, so it can be used when we really need biopsies. So the patients go have a CT enterography. And on this CT, we see that there are multiple ileal loops with wall thickening and hyperenhancement. And there is engorged mesenteric vessels. We call it the engorged vesa recta. And here is some typical circulations and sinus tracts on the mesentery. And also, we identify the most distal involved segments. It's about 8 centimeters proximal to the ileocecal valve. This can be reached by the ileocolonoscopy. So under this image, what is your diagnosis? So it is an ulcerative colitis, or who will vote for Crohn's disease? Or how about intestinal TB, or eosinophilic enteritis, or bowel ischemia? Okay, so because there is multiple segments of ileal involvement, and also there is a typical circulation appearance, this is most suggestive of Crohn's disease. So because the most distal involved segment is close to the ileocecal valve, so we told the clinicians, then they repeated the colonoscopy again. This time they inserted more deeply in the terminal ileum, and now they see multiple discrete ulcers. And this is typical for Crohn's disease. And they took biopsies, and also the pathology is consistent with Crohn's disease. So the diagnosis can be made. So for initial diagnosis, if the patient is suspicious for Crohn's disease, but with a normal ileocolonoscopy, then the small bowel should be examined, and we can use small bowel capsule endoscopy or the cross-sectional imagings to help to see if there's any abnormality of the small bowel. And if biopsy is needed, then the deep endoscopy can be used. And also, if the patient has abnormality on the colonoscopy and is already diagnosed as a Crohn's disease, they should still undergo small bowel assessment to define the extent of the disease. And ultrasound or MRE or capsule endoscopy can be performed. And for the imaging findings of active inflammation on the CT angiography, we can see segmental intestinal wall thickening, such as this one at the terminal ileum and the descending colon, and there will be mural hyperenhancement and an engorged vasa recta. These are the engorged vessels on the mesentery. It's called the comb sign. And we may also see ulcers. This is defined as the defects at the intraluminal side of the intestinal wall. Okay, on MRE, these are similar findings. Then compared to the CT, it's the same. We can see these findings on the post-contrast images. So this is the wall thickening, and this is the engorged vasa recta. And now we have ulcers here at the descending colon. And in addition to the findings that we can also see on CT, on MRI, we can see more. So on T2 weighted image, we can see wall edema. The signal will be higher on T2 weighted image compared with the muscles. And for the inflamed segments, it will have restricted diffusion on DWI. It can help us to identify the abnormal segments. And on intestinal ultrasound, similarly, we will see intestinal wall thickening. And there will be alteration of the bowel wall echo pattern, means that the loss of the normal stratifications. And on color Doppler ultrasound, there will be an increased vascularization if there is active inflammation. And the peristalsis will be reduced. And in addition to the intestinal inflammation findings, it sometimes can be non-specific. There are also some more specific imaging findings to suggest Crohn's disease, such as the asymmetric involvement of the mesenteric site, and more severe at the mesenteric site, and the saculations, these outpouchings along the anti-mesenteric site. These are the more specific findings for Crohn's disease. And also the mesenteric fibrofatty proliferation, which is the increased fat around the inflamed segment. This is also a very specific sign for Crohn's disease. Also, we can see penetrating complications, such as sinus tracts, fistulas, and abscess. However, there are also some differential diagnoses to be kept in mind, including appendicitis, diverticulitis, tumor, or tuberculosis. Okay, let's move on to the second case. This is a 16-year-old boy. He had a Crohn's ileocolitis with perirectal abscess and CMV colitis. So on the colonoscopy, there are ulcers and inflammatory pseudopolyps. And on MR enterography, this is the T2 weighted image. There is wall thickening and edema of the terminal ileum and also the sigmoid colon. and also wall thickening of the ascending and descending colon. And here is the perirectal abscess. So the patient received treatment and now it's in clinical remission. We had a follow-up image 1 year later, and now all of the involved bowel walls are returned to normal, and the perirectal abscess has resolved. So this is the condition that called the transmural healing, which means that all of the intestinal wall return to normal. And in the past, the treatment targets for Crohn's disease is clinical remission. And now we aim for the mucosal healing, which is the mucosa under endoscopy looks normal. And the transmural healing can be considered as a future target. So it can be assessed with the cross-sectional images, including ultrasound, MRE, or CTE. It's defined as the bowel wall, the intestinal wall thickness less than 3 millimeters. And if the patients can achieve transmural healing, it will have an improvement in disease-related outcomes. However, the rates of transmural healing is not high under current available treatment. It's less than 50%. So it cannot be a formal treatment target now, but can be assessed as a measure of the remission depth. Here is the third case, 36-year-old man with Crohn's disease. He had intravesical fistula, received operation 7 years ago, but loss of follow-up. And then he had abdominal distension and body weight loss. Also have leukocytosis and elevated CRP levels. Disease relapse is suspected. And this patient had an MRI enterography. So on this MRI, we see multiple segments of ileal loops with wall thickening and edema. And between the intestinal loops, there are some fluid collections with adjacent with the wall thickening and increased enhancement, and also has a high signal on DWI and low signal on ADC map. So based on the findings, what is your diagnosis? Okay, so actually the patient has indeed had a disease relapse with multiple ileal segments of active inflammation. And in addition, he also had an abscess formation. So for detecting the penetrating complications, the cross-sectional imagings are also very helpful. It can help to detect the fistulas and abscess. And however, if the perianal abscess or fistula is considered, then we should use MRI is suggested to evaluate the perianal conditions. Okay, here is the next case, 29-year-old man with Crohn's disease. He was diagnosed 7 years ago with intestinal stricture and had a right hemicolectomy. Now he presented with right lower quadrant pain. A CT was performed, and there is a large fluid collection at the right lower abdomen. And this is an abscess formation, and there is also inflammatory changes of the ileal loops. So for this abscess, what would you suggest for the treatment? Would you consider percutaneous drainage or surgical drainage? Okay, so for the abscess, we of course we use antibiotics, but these large abscess need to be drained, and this is accessible, and so percutaneous image guided drainage is suggested, and CT guided drainage was performed. We inserted a pigtail catheter for the drainage of the abscess. So for the treatment of abscess, if it is well-defined and is accessible intra-abdominal abscess, the percutaneous image-guided drainage is suggested as the primary approach rather than go for surgery directly. And successful drainage rate is about, it's high, it can be up to 100%. However, if the abscess is multiple or multilocular or with a fistula, then it's more prone to failure. And the percutaneous drainage can help to avoid surgery in 29% of patients. And it can also act as a bridge to elective surgery. So it can allow the patient to have time for nutritional and medical optimization. And the patients can have primary anastomosis after surgery rather than to have an ileostomy or colonoscopy. Okay, now here is the last case, the 57-year-old woman with Crohn's disease. She had a disease for a very long time, more than 20 years. Now she presented with abdominal fullness and pain. So on this MR enterography, there is at least 2 segments of luminal narrowing and stenosis at the ileal loops and with prominent proximal intestinal dilatation. So what is your diagnosis? So we know that there are intestinal strictures, and it is now important to see if it is an inflammatory predominant stricture or a fibrosis predominant stricture, because the treatment will be different. Okay, so because this patient does not have edema, we see that this T2 weighted image, the signal is actually not very high. So there is no edema and there is no cold sign or adjacent mesentery edemas. So this is more likely a fibrosis predominant stricture. So cross-sectional imagings are helpful to detect the small bowel strictures in Crohn's disease. And imaging will appear as a segmental luminal narrowing with unequivocal upstream dilatation. Most of the strictures, actually, they have both inflammation and fibrosis component, but one of them will be predominant. And if fibrosis predominant strictures, there will be less responsive to medical therapy. So in these strictures, we'll consider balloon dilatation or surgery. So we can assess the degree of inflammation by using the image like MR enterography, but it is still difficult to determine the degree of fibrosis. Some investigators, they found that the delay enhancement on MRI and magnetization transfer imaging or ultrasound elastography may help, but these still need further validation. So the current approach to the intestinal stricture in Crohn's disease. So first we have to see that identify if there is any signs of active inflammation on the images. So we look for if there is wall edema and cone sign. And so if there is no signs of active disease, then it will be presumed that this is a fibrotic stricture. And so we'll consider non-pharmacological options. And if there is active disease, then should go for the medical therapy to treat inflammation first. If there is response, then there can go for maintenance therapy. If it's not resolving, then it's also presumed to have a fibrotic stricture. So back to the patient, what is the treatment recommendation? So we know that there is fibrosis predominant stricture. And how can we choose between the balloon dilatation or surgery? So actually this stricture is it's quite long. It's about 7 centimeters. So the endoscopy balloon dilatation is reserved for the short strictures, often less than 3 centimeters. So these patients need to go to the surgery. Okay, so in summary, the role of radiologist in the management of IBD will include at first, when the diagnosis, we can help to rule in IBD if we see typical findings on cross-sectional images. And also we can identify if there is alternative diagnosis. And we can help to evaluate the disease extent and activity, and can monitor the treatment response, especially for the transmural healing, and to detect complications such as abscess and fistula and strictures. And if there is abscess, we can do image-guided drainage. Okay, thank you for your attention.